Welcome back to my channel. It's Dr. Jessica Katanga, and in today's video I'm going to be talking about my psychiatry placement. So I am currently in F2 and my placements for the year have been academic, then psychiatry, after this is neurology, and I cannot believe that I've not actually sat down and talked about my foundation experience at all. But let's just start with a video on my psychiatry placement. So get yourself a cup of coffee or a cup of tea and let's get into it. So what I'm going to be talking about, how my week is split. So I do clinical trial work, so my research work, and I also do clinical work on the ward. And then I'll talk about how everything is day to day, what challenges I've faced, how I'm finding it so far, what I've liked about it, and whether I still want to do psychiatry or not. So let's get right into it. So how my week is set up is Monday and Tuesday I am a medic in a clinical trial, and then 3 days I'm on the ward. So let's talk about the clinical trial first. So the clinical trial is looking at the use of pramipexole in treatment-resistant depression. So pramipexole is a dopamine agonist. Dopamine is the chemical for rewards in your brain. And treatment-resistant depression is defined as depression where somebody's tried 2 antidepressants or more and they're still unwell. So for that clinical trial, what I have to do is do pre-screening, where I take a full depression history, and then I do the screening as well, where there's like a full questionnaire. I have to rule out psychosis, bipolar, mania, to make sure that they are eligible for the trial. I have to also rule out, because dopamine is a reward system in your brain, as I said, I have to rule out whether they have any signs of impulsivity. So I'll ask about alcohol history, gambling history, criminal history, things like that. So, and then now for my clinical work, I'm on an adult female inpatient ward. And the way that the day is set up is we have ward rounds in the morning, which is like virtual. So it's just like a meeting where the nurse is going through each patient and saying any of the concerns or any outstanding tasks and that's the whole MDT that's there. So they'll say that, then that generates a list of jobs, and then we're sent the medic's list of jobs. So that will be any prescriptions that need to be done, anybody who needs to be reviewed. So if their mental state is deteriorating, then we'll usually go review them with the reg and the consultant. And what else? And then through the day we'll just be going through the jobs, and if any physical things come up, so if they do their OBS, and they don't really do OBS that often on a psych ward anyways, they'll call us to review them and stuff. So have to do any new admissions that come in, we have to clerk them in, do a mental state exam, do a physical history exam, do a physical history and do a physical exam. Some people have, if you're on call and you're receiving a patient in the middle of the night or something, they might have been found in compromising situations. So a lot of people, maybe they've been like wandering around, or maybe some patients might be like homeless, or their first contact might have been with the police or something. So you have to do a physical exam to make sure that they're not injured and that they're okay. I really like the fact that I have that split between outpatient clinical trial type stuff and then inpatient stuff. And it's really nice to see, because then now I see like a range of kind of like wellness, because obviously the outpatients, they're less unwell than the inpatients. But then at the same time, you do still see that the people can be in community with quite debilitating depression but still going on, or they might have like low level psychosis but they're in the community and it's not causing them that much distress, and they've never seen like a specialist before, they've just seen their like GP for it. So it's quite nice, because even if they're ineligible for the trial, then we'll still give their GP treatment. I talk about them with my consultant psychiatrist, and we think about what treatments they should have, and we give those treatment recommendations to their GP. And in terms of the like inpatient stuff, that's so interesting, especially when you have new admissions. So the type of stuff that we're seeing is like bipolar, psychosis, and that could be drug induced or schizophrenic or stress induced. What else do we see? A lot of personality disorders, mostly borderline personality disorder. Any other questions, then just drop them down in the comments section. Some of the challenges that I've faced during my psychiatry placement. Okay, number one, the rota. So even though the job itself is much more calmer than, for example, a hospital job, the rota and the rota coordinators of this placement, I'm so sorry, but they've been very disorganized. So my rota has been swapped over. A lot of my on-calls were front loaded, so I felt like for Christmas holidays, I felt like every other day I was on call and I was there by myself, so that was really stressful. And I was revising for the MSRA. It was so stressful, and I think I'm gonna talk about that in another video, just about how I'm feeling about medicine in general. And now I'm a little bit burnt out. So if anybody else is feeling that way, then please give me any words of encouragement, or let me know if you'd want me to elaborate on that and what my plans are going forward, type thing. Another challenge is that you see that mental health is really, and the reason why I love psychiatry is because it is so linked with your, like, you know, with your personal well-being and just humanity. And unfortunately, a lot of these inpatients, they have been at the hands of the worst of humanity, unfortunately. So they come from very, very traumatic backgrounds, and then they might present with very, very traumatic self harm and things like that. That's very difficult to deal with. And I talked to my clinical, and that's one tip that I would give: make sure that you talk to somebody about that, because it was actually getting me down. So I talked to my clinical supervisor about that, and I talked to the lead consultant of the rotation to say that, listen, you guys are used to this, but we're not. Like, in terms of us foundation doctors, we're just 20-something-year-olds who have just come out of med school, and we're talking about all this trauma as if we're just talking about diabetes. Like, it's not normal. So you guys need to realize that it's not normal, and that this is actually affecting us and things. And then I was saying to my clinical supervisor that, like, in med school, psychiatry placement traumatized me, because we had to do a forensic psychiatry place visit during that time, and that was just, that blew my mind in the worst way. And then now this is slightly traumatizing me, so I was just like, oh, maybe psychiatry is not for me. And he was just like, oh no, don't think like that. Like, we want psychiatrists to feel something and feel something for their patients. We don't want, like, emotionally cold people. It's just about you feeling these things, and then us, so like them then helping me process those stuff in a productive way, type thing. And he was saying that, you know, them as seniors and more experienced, they should be more cognizant of that and to be helping us and stuff. So I'm just like, yeah, that's true. And one thing that we do every week is a balance group. It'll be on Teams, and then, like, one of us will talk about a patient that we found difficult, or that touched us, or like an interesting patient. So I think one of the doctors one week talked about one patient that, like, assaulted them, and then I talked one week about having to do seclusion reviews, and that just felt like, to me, and yeah, then we talk it through. And there's two, and the people who, like, chair the group are two ex-doctors who have now taken psychotherapy courses. So they're like psychologists as well as medical doctors, and it's cool. It's like a group counselling type thing, and it's actually very useful, and we see things from the patient perspective, and we put ourselves in their shoes. And at first I didn't know whether that was a good thing, because I felt like I was feeling their emotions too much, so should I be increasing my empathy even more? But then again, my clinical supervisor said yes, it is important, because empathy is a tool of how we can process emotions. I'm also doing an audit looking at fasting times for ECT. So there's also electroconvulsive therapy clinic in my building, and I want to go watch that one day. So ECT is inducing controlled seizures, and it's usually used for treatment-resistant depression to make people better, and it does really help patients. So I'm excited to see that. And yeah, so that's been the psychiatry placement so far. I'm like halfway through it. I think my tips would be, if if you feel like you are getting affected, make sure you talk to someone, because other people do feel it that way. Make sure you go to Balance Group, because it's actually a really useful session. My Reg is also really like nice and supportive, and he likes to teach. So whenever we see anybody, then I just ask him about it, and like he'll talk me through it. So like we did a really good teaching session on bipolar, the acute treatment, and then the maintenance treatment. We did like really good sessions on like schizophrenia and psychosis, and the it's just so interesting. Like psychiatry is so interesting. At times it is so sad, and like the things, as I said, the patients I've been through, you feel so sorry for a lot of them. But then at the same time, you also see so many of them getting so much better. And I would say like the on-calls, that is where I've learnt the most, because I've been able to do a full mental state exam when somebody is their most unwell, and then like a week or two later you see that they're so much better, and they're a completely different person. Like it's mind-blowing. Like psychiatric drugs actually, they proper work, and psychiatrists do very important work. So I think it has made me want to do psychiatry more, but I realized that I think it's like maturing me to know how to balance empathy and your clinical work, and balance your own feelings and patients' feelings. So I think that like even though I was finding it difficult at times, that's like part of my getting better as a doctor, and hopefully a future psychiatrist type thing. So I'm feeling quite like hopeful, and I'm really enjoying the placement so far. Yeah, so that's been my little summary of psychiatry. I hope you've enjoyed this video. I am gonna be doing more YouTube videos this year. You will see me here on the tube, okay? So comment below if you've liked this, like, share, let me know any videos that you'd like to see from me, and I will do them for you. Because yeah, 2023, let's just be our best selves, really. So thank you for making it to the end of the video, and I shall see you in the next one. Bye.